Go ahead, Isaac.
Okay, so good morning, everyone. Good morning to our doctors and to my classmates. We are section B, subsection B3, and we'll be presenting about the general plan of action for patients with lower GI bleeding. So for the salient features of our case, our patient is a 78-year-old female whose complaint is hematochezia. 6 hours prior to admission, the hematochezia was only half a teaspoon of blood. 2 hours, it progressed to 1 tablespoon of blood. And 30 minutes prior to admission, it progressed to 2 cupfuls and is now accompanied by dizziness and cold, clammy perspiration. Our patient is also a diabetic and hypertensive, and she also takes 80 milligrams of aspirin per day and clopidogrel. She has 19 pack years of smoking history and denies alcohol intake. She also has history of constipation for several years, to which she takes Bisacodel for relief, and she has no history of malignancy, no family history of malignancy. Upon physical examination, our patient was pale, awake, and weak, but not in distress. She has orthostatic hypotension, and she is tachycardic at 110 beats per minute. Her abdomen was symmetrical, flabby, and non-tender, and there was no palpable mass.
Go ahead, Isaac. Na-disconnect yata siya.
Sabi ni Jose Paulo, kinabahan si Isaac. Bakit Isaac?
Quit na daw.
Would any of the rest of the group like to pick up where Isaac left? Dr. Chan, bawal po ngayon yan. Bawal po ngayon yung coconut.
Kukuruk-kuku. Ay, wala daw siyang microphone.
Hi, hello, Doc. Sorry.
Ayan na, Isaac. Okay, welcome back.
Okay, so I'll start again from the objective salient features. So our patient was pale, awake, and weak, but not in distress. She had orthostatic hypotension, and she was tachycardic at 110 beats per minute. Her abdomen was symmetrical, flabby, and non-tender. There was no palpable masses nor organomegaly, and upon digital rectal exam, there was fresh blood on the examining finger. So discuss now the general approach to lower GI bleeding. So lower GI bleeding is classified as bleeding distal to the ligament of Treitz. So this is a suspensory ligament attached posteriorly to the duodenojejunal flexure. It's important to differentiate from upper GI bleeding, and as with any case, the initial evaluations include a complete history, physical exam, and ancillary procedures such as laboratory tests to further support the initial diagnosis. So I'll go back to the salient features, and I just like to highlight which features would more likely point out lower GI bleeding. So I'd like to point out that there is hematophagia, which is more likely pointing out to lower GI bleeding. However, this can also present in brisk upper GI bleeding, as I'll discuss later on. And there was also fresh blood on the examining finger, which supports hematochezia and lower GI bleeding as well. So for the general approach to lower GI bleeding, the initial assessment would include assessing whether the patient is hemodynamically stable or not. So we can use clinical manifestations such as your tachycardia, orthostatic hypotension, and which presented with the patient, as well as yung cold clammy perspiration niya, which would suggest that the patient is already in some sort of dehydration or hypovolemia. So after you have assessed the stability of the patient, you can now assess whether this patient is high risk or non-high risk. So if the patient is hemodynamically stable, we can see here
I
that yes, doc.
To the point of the discussion you are in based on this algorithm.
Um, so basically, if you're hemodynamically stable, we need to be more aggressive, and if you're not hemodynamically stable, we need to refer to if the patient is high risk or not. So if he's older than 40 years old, we need to do colonoscopy agad. However, if he's younger, um, we can manage more parang more, tawag dito, parang more leniently than as with higher risk patients.
Conservatively,
So
not leniently, conservatively. You cannot
um
be, the lenient is not the word.
conservatively, doc, yes.
Because you just go to the right hand part of your slide.
Apo, doc.
That's where the patient belongs.
Apo, doc. So you can see here on the right side that since our patient is already hemodynamically unstable, we need to do an upper endoscopy. So why is this? Since this is lower GI bleeding. So this is because usually if the patient is hemodynamically unstable, um, it can it can be due to uh, severe bleeding in the upper GI, which can also present with hematochezia. So that's why it's important to rule out any upper GI lesions first before looking out in the lower GI bleeding. So if you're able to prep the patient, if the patient was stabilized, we can do colonoscopy. However, if the patient is too unstable for preparation, we can proceed to your CTA angiography.
So, Isaac,
So, yes, doc.
Isaac, um, can patients with lower GI bleeding also present with hemodynamic instability?
Yes, po, doc, of course.
Okay, so do you can you think of a reason why in your book in the algorithm that if you have hemodynamic instability with hematochezia, it's upper GI endoscopy is the first, it's the first procedure that you have to do. Why not colonoscopy? Since you're saying that even patients with lower GI bleeding can also present with hemodynamic instability. Why not colonoscopy?
I think, doc, because it's also important to rule yung upper GI first, and parang mas madali rin po gawin yung upper GI endoscopy since
There, that's
hindi
the
po siya kailangan
reason.
ng
Yes, that's the reason. For upper GI endoscopy, you don't need much preparation. You can go ahead and do
apo.
the upper GI endoscopy. If it's from the upper GI, then you can see the bleeding. Colonoscopy, you need to prepare the patient before you're able to do it, and that's the reason why upper GI ang first ano. But just the point that I wanted you guys to realize is that hemodynamic instability in the presence of hematochezia does not always mean that it's upper GI. Kasi if you look at the algorithm, you might think, oh, upper GI yan. But it can be lower GI as well. It's just because it's easier to do the endoscopy if it's upper in these kind of patients. Okay,
Yes,
proceed.
doc. So, yung nga po, after yung CT angiography, the bleeding still persists. That's the point where we start to do with surgery, so to treat the bleeding. So I'd like to
Yeah,
present
that's
another
fine.
algorithm
All right.
again.
Okay.
So this one is taken from the British Society of Gastroenterology, and I just like to point out here that aside from clinical manifestations, this algorithm uses a more objective way of assessing the um, risk of the patient using your shock index, which is calculated your heart rate divided by systolic blood pressure. So again, if it's high risk, you present to CT angiogram. If it's low risk, you can treat more conservatively. And also, I'd like to point out here, in relation to the patient, that under here you can see that we need to consider dose or in your anticoagulants and antiplatelets. So since our patient is in aspirin or clopidogrel, we may need to discontinue these drugs if the patient has no risk of um, if we need to weigh the balance between the benefits and the cons of using these drugs in this case. So let's move on.
Hello, good morning.
Go ahead, Clinton.
So here we're going to discuss different differential diagnosis for our patient presenting with lower GI bleeding. So here we have a table of one of the more common causes of lower GI bleeding. We have diverticulosis. For vascular causes, we have angiodysplasia, hemorrhoids, ischemia, and the others, which is basically either dilatation of blood vessels or actual damage to the blood vessels causing bleeding. We have inflammatory causes, which includes infection or the actual inflammatory process of the body. We have infection and inflammatory bowel disease and neoplastic or cancer. So for actually all of these are very plausible causes of lower GI bleeding. So why do we consider the others more than these? So hemorrhoids, it should actually uh, present with pain, and
No,
we
not
should
necessar
doc.
not
Okay,
necessarily,
doc. Yes,
Clinton.
doc. It's either we have pain or we can assess and see lesions or examine them, which is not present in the patient. So for ischemia, also should present with pain, abdominal pain, and also if it is present now, since it is the first I mean, since kaka-start pa lang ng bleeding, if ever man ischemic siya, since progressive siya, baka kaka-start pa lang. Ayun yun, dapat nga may pain. And for infection, we don't have fever and diarrhea.
Clinton.
Yes, doc.
There are very few absolutes in medicine. So
Yes, doc.
it's better to say usually presents with pain rather than it should
Okay, doc.
present with pain.
Okay, doc. Okay,
Okay.
doc. Yes, doc. So, it usually presents with pain. So, the three most probable causes are uh, the diverticular disease, angiodysplasia, and malignancy. So, why diverticular disease? According to the history of the patient, she has chronic constipation and aspirin use, which predisposes her to the development of diverticular disease. For angiodysplasia, the patient is of old age.
Quinton,
Again,
the aspirin does not predispose you to diverticular disease. It
uh,
does not
let
predispose
me
you.
rephrase that now. The
Yes,
aspirin use predisposes the patient to bleeding
of
for
course, yes.
the
Bleeding,
yes, doc.
correct.
For the bleeding. Uh, it actually aggravated the diverticular disease causing the bleeding. Same is true with angiodysplasia. The aspirin use only aggravates the bleeding. Angiodysplasia we consider because of the patient's advanced age, chronic constipation, and hypertension. And for malignancy, the patient is of old age and has a smoking history. So yeah, we consider malignancy.
Clinton?
Clinton,
Yes,
Clinton?
doc.
question.
Yes, doc.
Okay, Dr. Isabel first.
Uh, you mentioned AIDS in angiodysplasia as well as in malignancy.
Yes,
How
doc.
about in diverticular disease?
Hmm. Uh,
Anyone in the group can answer if Clinton will not be able to answer that. Jade, you would like to help Clinton?
Yes po, Doc. In my report po, I will say that older age also predisposes the patient for
ooh,
diverticular
okay, okay.
disease.
Okay, very good.
Or please.
Thank you, Jade.
Yes. Yeah, Clinton,
Yes, doc.
in this slide, you mentioned one particular symptom that is not present in the diseases that you mentioned in your differential. What is it?
That is present in the patient, doc.
No, which is not present. Look at the left side of your slide. There is a symptom there
Mm,
which you placed under two diseases, which is not present
i-
in the diseases under your
uh,
differential diagnosis.
is it pain,
What
doc?
is it? Pain.
Yung pain.
Okay. Therefore, if there's no pain
Yes,
in
doc.
this particular history or in this particular patient, then how do you label the GI bleeding? Because that will be your guide in coming up with the differential diagnosis. There's no pain, so just reward it.
We have painless GI bleeding,
Okay.
doc.
So this
Okay,
patient, in other words, to simplify, has a painless, massive lower GI bleeding.
Yes, doc.
And if you categorize it in that sense, then the priority in terms of your differential diagnosis will come up to be diverticular disease and angiodysplasia.
Yes, doc.
Okay?
Okay, doc.
So, to rephrase, our differential diagnosis for the case is diverticular disease, angiodysplasia, and colon carcinoma. So, for diverticular disease, the incidence and epidemiology of diverticular disease, diverticulosis affects 60% of patients that are more than 60 years old. And there is what we call an east-west paradox in disease prevalence and phenotype, but the reasons are obscure. So in Asian countries, it starts on the right side colon for extending to the left side and bilateral colon, and this is suspected to be congenital in origin. While in Western countries, it presents in the left colon, most commonly sigmoid colon, and that's why some books say it can manifest as left lower quadrant pain similar to appendicitis. But higher incidence overall is found in Western countries. For the incidence and epidemiology of lower GI bleeding due to diverticular disease, diverticulosis is the leading cause of lower GI bleeding, as most journals would say, and that hemorrhage from a colonic diverticulum is the most common cause of hematochezia in a patient that is more than 60 years old. And also, according to Harrison's, diverticular disease is also the leading indication for elective colon resection. So this is a study from UST Hospital done in a 5-year period. The overall prevalence was 20% with equal gender distribution. It was commonly seen in elderly patients, 60 years old and above, with a mean age of 62.5 plus or minus 12.4 years. Almost half had right-sided diverticulosis, while 27.6% and 28.9% had left-sided and diffuse type, respectively. So some of these cases had diverticulosis only as a sole finding, but majority of the cases had combination of lesions with hemorrhoids as one of the most common concomitant finding. So in patients with symptoms of diverticulosis, 20% were positive for diverticula, and hematochezia was the most common indication for colonoscopy. So this is
Jade,
just to show,
Jade,
yes po,
yeah,
yes po.
sorry. Just like to ask you, di ba, what did you notice? It is more common, the bleeding is more common in the
Hello po.
right-sided diverticulosis. Do you notice the bleeding diverticulosis is more commonly located in the right side of the colon?
Ah,
Did you notice? Di ba? You
hindi
were
po.
mentioning about the data being right side in more than 50%, another 20%. The entire colon is involved. Therefore, the right side is more common. Di ba?
Oh,
Can
okay
you
po.
tell us why?
Um, not sure po, Doc.
Uh, anyone, especially those who's the one who's going to present the pathophysiology.
Maybe, or it will be discussed later. We'll just wait for the pathophysiology.
Okay, po. Then we'll go back to this question and we'll correlate the manifestation. Okay.
Jade, can you go back to your previous slide just to put that in context? No, the other one, the one with
After
the,
this,
yeah, after, no, uh, no, the one,
ne-
the study of Dr. Soliano. Next, there. Okay, so does this mean it is lower GI bleeding that is referred to as far as location is concerned, or is it the diverticulosis?
I think po the lower GI bleeding is the usual presentation po and the reason that they would go to the hospital.
No, because if you look at the title of the study, it says the demographic profile. So it did not say GI bleeding. So this is in general the demographic profile of diverticular disease in this group of Filipino patients. Okay,
Okay po.
it's not really the bleeding. It is for example, location. The location of the diverticulum or diverticula that is being referred to here.
Ah, okay
Anyway,
po.
so
Thank you,
we'll
Doc.
go to the question of Dr. D in the pathophysiology. Thank you. Next.
Thank you, Doc. This is just to show po the trend that bleeding increases in incidence with age and that the lifetime risk of rebleeding is 25%. And then colonic diverticular hemorrhage increases in incidence with age again, and that the reasons include the widespread use of antithrombotic drugs since the early 2000s, based on the guidelines to prevent ischemic heart disease and ischemic cerebrovascular disease. So it's just one of the reasons that they think is the reason that they think is the cause of more bleeding, and that it is more likely in patients who are older, male patients who are obese, use NSAIDs or antithrombotic drugs, and have hypertension and diabetes associated with arteriosclerotic disease. But more of the pathophysiology will be discussed later.
So, diverticulosis is defined as a local or abnormal outpouching of a hollow organ. These are seen as sac-like herniations in the intestinal wall, seen here, and endoscopically they can be seen as these. These can range from 1 to hundreds in number. Meanwhile, diverticulitis occurs when there is inflammation of a diverticulum, thought to be caused by a low fiber diet, which usually has an acute onset due to obstruction. So, to understand the anatomy of diverticular diseases, let's first look at the histology of the normal intestinal mucosa. So, this is the mucosa, this is the muscularis mucosa, this is the submucosa, which will contain your vessels. This is your muscularis propria and your serosa, which contains fats. In the intestines, the muscularis propria is composed of an inner circular and an outer longitudinal muscle. The outer longitudinal muscle fibers of the colon form three distinct long bands of smooth muscle known as your taenia coli. These there two anti-mesenteric taenia, the omental and free taenia, and a single mesenteric taenia. These will flank the rows where diverticuliform, usually on either side of the mesenteric taenia and on the mesenteric side of either anti-mesenteric taenia. These four distinct rows represent where the nutrient artery, called your vasa recti, will will penetrate the muscularis propria and give off its major branches, resulting in a break in the integrity of the colonic wall. So there are mainly two types of diverticula, your true and your pseudo diverticulum. A true diverticulum involves herniation of the entire bowel wall, while a pseudo diverticulum involves protrusion of your mucosa and your submucosa through the muscularis propria of the colon seen here. So as you can see, this is your diverticulum, and it's lined by the mucosa and submucosa. The muscularis propria of your normal colon will no longer extend to the diverticulum. So this is the reason why in times of complications, the diverticulum is prone for complications because it's only supported by your serosa. So it is also common to see thickening of the longitudinal muscles, which will be explained later in the pathophysiology. Most diverticula that occur in the colon are pseudodiverticulum in nature. So the typical size is from 3 to 10 millimeters in diameter, while a giant colonic diverticula is defined as over 4 centimeters in diameter, and it's usually 30% more prone to complications. So most diverticula are found in the sigmoid colon because of the law of Laplace. So um, it will also tell you why bleeding is more common in the right side of the colon because it has the highest wall tension, which will be most prone for bleeding. So occasionally, a diverticulum can appear inverted, such as this one. And although it is rare, it's very important to take note of this because it can resemble a polyp endoscopically. But the difference is it can be reduced by air insufflation and it will also appear soft, called your piloside. So it's important to take note of this because it's prone for complications and it should not be removed. So, for the pathophysiology of diverticular diseases. So, it's primarily believed to be caused by a low fiber diet. Now, it has been determined that the cause of diverticulosis is multifactorial and incompletely understood. So, Schlesinger pointed to five main etiologic factors, namely your anatomic features intrinsic to the wall, altered colonic wall with aging, environmental factors, abnormal motility, and heritable factors. While Harrison's will also include dysbiosis, yes po, Doc. Dysbiosis and chronic low-grade inflammation. So predisposing anatomic features intrinsic to the wall is due to an increase in tissue inhibitor of metalloproteinases. Metalloproteinases regulate the deposition of extracellular matrix proteins like your elastin and your collagen, thereby increasing elastin content, which results in thickening of the muscular layers. If you can remember kanina, the thickening is not because of hypertrophy or hyperplasia, but because of increased elastin deposition, which and duodenal diverticulum. So which increases elastin content, which results in thickening and shortening of the tenia and increasing the contraction of longitudinal muscles, impairing the flexibility and resiliency of the colon wall, which overall increases the weak spots in the colon, generally weakening your colonic wall. So, with aging, there is increased synthesis of the less tensile type of collagen, your type 3 collagen, and together with the increased elastin and increased elastin, there's overall weakening of your colonic wall. So this pathophysiologic mechanism is responsible why diverticulosis is also seen in diseases such as your Ehlers-Danlos syndrome, your Marfan syndrome, and your scleroderma. Environmental factors such as a diet low in fiber, high in fat, high in red meat, obesity, smoking, and physical inactivity predispose to diverticular formation. But the most important of these in its pathophysiology is a low fiber diet, which will cause a slower transit time and decreased stool weight. Eventually, increased intraluminal pressure due to the presence and increased force of contraction needed to propel such stools. In patients with diverticula, there's a shift in the normal commensal bacteria towards a pro-inflammatory and pathologic population, causing dysbiosis. And this has been linked to increased immune mediators that will cause your chronic low-grade inflammation, eventually causing neuronal degeneration that will add to increased intraluminal pressure and dysmotility. So, according to Schlesinger, manometric findings in patients with diverticulosis found increased amplitude contractions and retropropagation of contraction waves, possibly caused by a deficient fiber in the diet, resulting to augmented hypersegmentation of the colon. There's also an increased cholinergic imbalance towards and decreased activity of non-adrenergic, non-cholinergic inhibitory nerves that will cause an imbalance towards increased tonicity. All of these four, will aggravate this motility in both magnitude and direction, which may concentrate the increased luminal pressure in a particular point in the colon. Therefore, in weakened areas of the colon, wherein there is increased intraluminal pressure augmented by this motility, diverticula develops. Also, studies done on siblings of index cases showed a 3 times increase in incidence. That's why it was also included. So, when the submucosal vessels, the vasa recti, are pulled into the diverticulum as they herniate, they become compressed, and the intima will thicken while the media will thin, thereby weakening the vessels, predisposing to complications such as perforations and bleeding. Thank you.
Wait. Isabella, can we go back? Can you repeat the part of your discussion that answers Dr. D's question earlier?
Um,
Just that portion,
according to
so that we
the
can emphasize on that. Yes.
according to Doxa law of Laplace, the that relates wall tension to luminal size and transmural pressure in a cylinder. The wall tension is equal to the
Go ahead. Go ahead.
wall tension refers to intramural tension. So the pressure
Right. And
difference
it's
between
because
the lumen,
yeah,
and
yes,
it's
it's
because
because the
po the
lumen.
right side greatest diameter po, Doc.
All right. Okay. So thank you, Isabella. Very good. Laura,
I noticed Alessandra has not reported in the analyst group.
Doc, sa final diagnosis po.
Okay. Sige.
Good morning. So for the
morning.
excuse me.
Good morning.
So approximately 80% of patients with diverticulosis remain asymptomatic throughout their lives. Whenever diverticulosis manifests, it typically presents with one out of the three patterns, such as the symptomatic uncomplicated diverticular disease, diverticulitis, or diverticular bleeding. Since our patient is bleeding, I'll be focusing on that. So the typical presentation of a patient with diverticular bleeding is the abrupt, painless, self-limited hematochezia, as seen in our patient. And most of these bleeds are self-limited and they stop spontaneously. Moreover, patients typically have few abdominal symptoms. And some patients may report of bloating, cramping, or urge to defecate. In addition, the abdominal exam is usually normal, but it may demonstrate tenderness to palpation. Severe bleeding, on the other hand, which happens in 3 to 5% of patients with diverticulosis, presents with tachycardia, hypotension, or may exhibit with orthostatic hypotension, which was present in the patient. Severe postural
Dr. Ruiz,
dizziness.
I'm sorry, Rhea.
Yeah.
Dr.
Yeah,
Yes
Rhea.
po.
Rhea, you mentioned tenderness. Why would there be tenderness in a
Yes, Doc.
patient with diverticular bleeding?
Is tenderness, abdominal tenderness, part of the manifestations of diverticular hemorrhage?
It may be due
This
to
has been,
inflammation po, Doc, from
y-
other di- other diverticular disease po.
no, if we go back to the
Ay, for the,
to that slide of your
yes,
classmate earlier, and it was emphasized by Dr. Ruiz at that point in time, that these types of bleeding are painless, no? Painless hematochezia. That's why we do not usually expect abdominal pain or abdominal tenderness in patients with hemorrhage. But I think you are talking about something else that is also part
yes,
or
Doc.
probably a complication of diverticular disease, and it's actually here in your slide. So
That's,
baka na mix mo.
yeah,
So which one is that?
po, sorry po, Doc.
Diverticu?
Diverticulitis po, Doc.
Okay. So if
Litis.
there's no diverticulitis, we're talking of pure diverticular disease that is bleeding, there should be no tenderness, all right? If on
Yes,
PE,
Doc.
for some reason, you elicited tenderness, then you think of another complication as other than bleeding, because bleeding and diverticulitis can simultaneously occur on a patient, okay?
Okay, Doc.
Okay, go on.
So, thank you, Doc. So, for the severe bleeding, it happens in 3 to 5% of patients with diverticulosis and may present with tachycardia, or orthostatic hypotension. Severe postural dizziness and a postural pulse increase of at least 30 beats per minute happens in acute blood loss of more than 630 ml. Late signs of this bleeding, severe bleeding, are poor skin turgor, dry skin, and altered level of consciousness. And blood is typically and may be bright red, dark, or melanic. Sorry po sa aso. And then po, for the next slide,
Okay, Rhea, sorry.
yes po, Doc.
Okay, we have to emphasize to everybody that the symptomatology that you have presented, can you go back to your previous slide? The symptomatology that you have presented, like tachycardia, orthostatic hypotension, postural dizziness, etc., are not specific to diverticular bleeding. Okay, so these are
Yes po,
manifestations
Doc.
in general of massive bleeding, either from the GI tract or outside the GI tract.
Yes po, Doc.
Okay.
So we're focusing on the diagnosis. So before going to diverticular bleeding, I'll mention first the diverticulitis, wherein its gold standard is abdominal CT scan with contrast, and ultrasound may also be used. In addition po, colonoscopy is contraindicated due to increased risk of perforation. So for the first step in the management of diverticular bleeding is to make sure that the patient is hemodynamically stable before proceeding to any diagnostic procedures. The recommended first-line diagnostic modality for bleeding is colonoscopy, and it has the ability to directly visualize lesions, allowing for the exclusion of other causes of lower GI bleeding, and also for immediate therapy. It has a diagnostic yield of 69 to 80% in acute lower GI bleeding. The picture below shows an Example of a patient with lower intestinal bleeding from a diverticulum in which an active bleeding was identified. So, if colonoscopy fails to localize or treat the bleeding source, and active bleeding is still present, further evaluation with nuclear scintigraphy or tagged red blood cell scan or angiography can be done. So the nuclear scintigraphy is non-invasive and it can detect bleeding rates as low as 0.1 per minute. However, it can only identify the site, not the etiology of the bleeding, and it has no therapeutic potential. The pertechnetate tagged RBC is often used due to its longer half-life, allowing for the visualization of active and intermittent bleeding up to 40 to 42 hours from time of injection. Moreover, it may also serve as a gateway to angiography to select a specific artery for injection of contrast. Lastly, mesenteric angiography is both diagnostic and therapeutic. Same with colonoscopy. It can identify the bleeding site to direct segmental surgical resection or angiographic intervention via embolization. It can detect rates of bleeding in a range of 0.5 millimeters per minute. Thus, these are the modalities to diagnose bleeding. In summary po, colonoscopy and mesenteric angiography are both diagnostic and therapeutic.
Dr. Del Rio,
Yes po, Doc.
you mentioned that the colonoscopy and the angiography are both diagnostic and therapeutic at the same time. Okay, so what would make you choose one over the other?
Sorry po, Doc.
Huh?
Ano po yung
When,
question po?
Doc,
that, yes, go ahead.
Rhea, the question of Dr. Chan is, when will you choose one modality over the other? If you're saying that both colonoscopy and mesenteric angiography can both be diagnostic and therapeutic, so why will you choose one over the other?
Since colonoscopy po is the first line of for the first line of modality for the diagnosis of bleeding. However, you would only resort to mesenteric angiography if you weren't able to locate the source of bleeding in colonoscopy.
Dr.
And
Del Rio,
what's
All
go
right.
ahead, Derek.
Rhea, of course, when the patient, if you look at the initial approach, if the patient is hemodynamically unstable and you cannot prepare the patient, then angiography would be a better choice. Now, you mentioned, Rhea, a while ago that angiography is both diagnostic and therapeutic. Diagnosis for what? I just want to be clarified.
Okay po, Doc.
Diagnosis for
Diagnosis for what
what, Rhea?
daw?
Di ba you
maybe that is shown in your, yeah, that slide. Okay.
Yes.
So can you diagnose diverticular disease as the probable cause of lower GI bleeding using mesenteric angiography?
Doc, I'll
Are
get
there
to that po.
characteristics? Okay.
Before that po, I would just like to mention to show the pictures po. Is that okay?
Yeah. Go ahead.
Go ahead, Rhea.
Um, so this is, as I mentioned earlier, this is colonoscopy po. And then for the lower left, this is nuclear scintigraphy using the tagged RBC, wherein the site is only shown, not the etiology. You can see the pooling of the RBC in the right upper quadrant. And then the subsequent images show the radio-labeled RBC progressing through the transverse colon over time. And according to the European Associated Nuclear Medicine, large bowel bleeding has a more linear pattern and typically occurs in the periphery of the abdomen or the pelvis. And in the upper right picture, this is mesenteric angiography. The site of bleeding in the ascending colon is in the ascending colon with extravasation of contrast material as seen in the arrow. And then you can see there that this has been embolized with microcoils. For the lower right, this is the surgical intervention of colectomy. Although surgery is avoided unless the endoscopic or angiographic therapies are unavailable or fail.
All right.
Segmental colectomy.
Uh,
Yes, Doc.
so Rhea, can you now answer Dr. D's and Dr. Ismael's question based on these pictures? These pictures actually will already help you in answering that question. Kasi ang question ni Dr. Dio is, what will you be able to diagnose using these modalities, using the tag scan or the mesenteric angiography? Kasi you're talking about your specific topic right now is diverticular bleeding. Okay, so ang question is, will you be able to say na you have diverticular bleeding using a tag scan or a mesenteric scan, mesenteric angiography?
Doc, the location of bleeding.
So it's going to tell you that there is bleeding, but it's not going to tell you that it is 100% coming from a diverticulum. Unless, for example, here in the uh, uh, colonoscopic picture, you see this diverticular opening and you see bleeding. So you know there is a bleeding site and it's coming from a diverticulum, whereas in the scans, a tag scan and a mesenteric angiography, it's just going to tell you that there is extravasation of
Yes, Doc.
blood. So it's telling you there's bleeding, but it's not telling you that it is diverticular bleeding. So did you get that?
Yes po, Doc.
And that is why, Rhea, I ask you if there are mesenteric angiographic signs of diverticulosis that will tell you that probably the bleeding is coming from that diverticulum. Wala? Meron.
Hello, hello.
Hello? So are there angiographic signs that will tell you that that the bleeding is coming from the diverticulum? Meron ba o wala?
Rhea, are you still there?
Wala po, Doc.
Okay, so the only diagnostic procedure in this particular slide of yours that will tell you that the bleeding is really coming from the diverticulum is colonoscopy. Okay, as far as diagnosis is concerned.
Yes po, Doc.
Okay, okay. So
Thank you, Doc.
yun lang para maliwanag. Okay, so go on, continue.
Okay.
So this is the management of patients with diverticular hemorrhage. So as I've said earlier, the initial step of management is to assess the hemodynamic stability of the patient and do the necessary measures of correcting it, such as with fluid replacement, blood transfusion, administration of oxygen. And since our patient is hemodynamically unstable, presenting with hypotension, tachycardia, there is a need to stabilize the patient. The patient is also taking antiplatelet drugs, which should be discontinued to prevent more bleeding. However, according to the study of Mizuki, dual antiplatelet therapy should not be discontinued in patients with acute coronary syndrome within the past 90 days or with bare metal stents placed within the preceding 6 weeks or drug-eluting stents within the preceding 6 months. Also, That's why it is important to get a thorough history of the patient and to coordinate with the cardiologist of the patient. And then next is if the patient is still unstable, you should resort to the angiography.
Rhea,
To the yes, doc.
Rhea, sorry. Did I get you correctly that antiplatelet agents should not be withhold in patients with GI bleeding for patients with with patients who have undergone coronary manipulation?
If the patient is taking dual antiplatelet therapy, according to the study lang po na it should not be discontinued with patients with acute coronary
Um,
syndrome.
okay. I may want to read on this, but for most of the guidelines, what they're telling us is that you stop it and do the necessary treatment. But once you have done the necessary treatment, it should be reintroduced immediately
Yes po, doc.
rather than not stopping these antiplatelet agents.
Yes po, doc.
Kasi it was mentioned a while ago by one of your classmates that one of I think by Del Campo, he's telling us that we need to withhold this, the antiplatelet agents, anticoagulants. All right?
Yes, doc.
Yeah, the reason for this is because we know that antiplatelets and anticoagulants can precipitate and aggravate the bleeding. That's why when you haven't given your therapeutic intervention to address the bleeding, it is more prudent to stop it. And then when you have done your therapeutic modalities, it is then that you are going to, and when you deem it safe, it is when you resume the antiplatelets and the anticoagulants because you have the chance to increase morbidity and mortality that is cardiovascular in origin for patients who really need it, but you withheld it. Okay?
Yes, doc.
Sige, continue.
So if the patient is still unstable, angiography is performed to determine, as I've said kanina po, the site of bleeding. And after identifying the source of the bleeding, supraselective arterial embolization with microcoils is done to occlude the bleeding. However, if the patient is still unstable and the embolization was unsuccessful, there is a need to perform segmental colectomy. And in next is the if the patient is hemodynamically stable, colonoscopy is done to determine the site of bleeding. And then if their endoscopic therapy is performed when the stigmata of active or recent bleeding is identified. This includes this includes epinephrine injection, coagulation, clipping, and ligation. However, if the source is still not confirmed and the bleeding persists, you may resort to tagged RBC scan. And then if the site is located, uh, mesenteric angiography. And however, if in patients with persistent life-threatening bleeding and there is no identification of a likely bleeding site, a subtotal or blind colectomy may be required as a last resort. So, overall, the risk of rebleeding after treatment should also be noted, since there is a 25% chance of recurrence of bleeding, which may eventually lead to surgery. So, in summary, we think this can be from diverticular bleeding because the patient had abrupt painless episodes of hematochezia, and also the patient has signs of hemodynamic
Sorry,
instability.
Rhea, what type of
Yes, doc.
hematochezia was it again? You said
Abrupt
abrupt,
painless
painless
episodes of
hematochezia.
hematochezia po.
Okay.
So for our next differential, we have angiodysplasia. So angiodysplasia is the formation of aberrant blood vessels throughout the gastrointestinal tract, seen as ectatic dilated submucosal veins, commonly in the colon and small intestines. So these vascular lesions may obscure GI bleeding in adults, especially among older adults and those taking antiplatelet and anticoagulant drugs. This is also associated with the following diseases: CKD, cirrhosis, rheumatoid disorders, and severe heart disease. And they may manifest as occult bleeding or iron deficiency anemia. For the pathophysiology, angiodysplasia is formed from the partial intermittent low-grade obstruction of submucosal veins in the muscularis propria during muscular contraction and distension of the cecum over many years. So this would cause repeated increase in pressure and dilatation and tortuosity of the submucosal vein and later of the venules and capillary. The precapillary sphincters would lose their competency, forming a small EV fistula, which would lead to retrograde flow to the arterioles. This could lead to possible local ischemia and also bleeding. So here is the figure presenting the development of angiodysplasia. So in figure 8, this is the normal picture. So you have the vein, the capillary ring, and the muscle. So in figure B, there is muscular contraction and increase in pressure in the vein. So it is partially obstructed. And then in figure C, after many years of repeated episodes of this, so there would be submucosal vein dilatation and tortuosity. So this is the stage that accounts for the slow emptying vein on mesenteric angiography, to be discussed later. And then here in figure D, you have the vein and the venules draining into the abnormal submucosal vein becoming involved. So there's also dilatation and tortuosity. And in figure E, you see that the capillary ring has also been dilated and tortuous. So the precapillary sphincter becomes incompetent. And then a small arteriovenous, so this is the artery, arteriovenous malformation or communication is presented through the angiodysplasia. Here are the other mechanisms for the formation of angiodysplasia. So hypoxia brought about by the constriction of the vein. It upregulates the VEGF and VEGF1 receptor. Also, the von Willebrand factor regulates angiogenesis like the VEGF. So the inhibition of the VWF would increase angiogenesis, increase VEGF receptor proliferation and migration, decrease integrin responsible for adhesion. Thus, there is formation of new blood vessels. Finally, because angiodysplasia can occur elsewhere in the GI tract, there are other mechanisms proposed, including response to mucosal irritation, local ischemia, and also upon radiation.
Hello. So for the clinical manifestations of angiodysplasia, uh, most patients with angiodysplasia are often asymptomatic, and these lesions are typically found incidentally in routine endoscopic procedures. However, in case it bleeds, it is typically recurrent and low grade, and if it bleeds, it can also present as massive hemorrhage, especially in older patients taking antiplatelets and anticoagulants. So the degree of bleeding may vary in the same patient.
Jose,
Yes po.
can you go back to your previous slide? Okay. If you say it is recurrent and low grade, how then will they manifest?
Uh, they would manifest with episodes of bleeding po, Doc. Then it would spontaneously
Low
stop in
grade
most
eh.
cases.
Low grade, especially if, for
Yes,
example, the
usually they
angiodysplasia on the
manifest
right
po
side.
with with iron deficiency anemia po.
Okay. So these patients may come to you. The presentation is not really a GI referable to the GI tract, but they can present to you with chronic iron deficiency anemia. So it just tells you that for patients with anemia, then one of the organ systems that you have to evaluate would be the GI tract. Okay,
Yes, thank you po, Doc.
go on.
So the degree of bleeding in one patient may vary. So it can range from one episode of melena to another episode which has bright red hematochezia, and these factors are influenced by yes po.
Yeah, maybe we can skip this because this is a generality. I mean, this discussion should be in the general approach.
So these are the different factors that can predispose an angiodysplasia to bleed. So increased interluminal pressure in constipation, hypertension, and old age, since the vessels are more fragile and more prone to damage. So again, as I mentioned, angiodysplasia, if massive hemorrhage is present, can present with melena, here as seen in the picture in the bottom of the screen. However, in most cases, patients will present of signs of iron deficiency anemia, such as easy fatigability, pallor, and shortness of breath. And in 90% of cases, they spontaneously stop, which will then cause a patient to develop uh, intermittently positive fecal occult blood test. The picture on top po is a tired elderly po.
Yes, Dr. D.
Yes, Jose, I'm confused. Your patient has hematochezia, and then you're telling us that patients with angiodysplasia, they present with tarry stools.
Yes, doc. Patients with angiodysplasia can present with either hematochezia and melena po, and sometimes even no
Okay,
bleeding po.
yes, I'm just pointing it out because it's not in your slides.
Uh, it's here po, doc.
Yes,
The
I
different
know,
factors will
but in that
influence
slide
it.
presenting, it's not there.
Okay po, doc.
These are clinical manifestation of patients with GI bleeding. But when you talk about angiodysplasia, move forward on your slide. One more. Yes. Clinical manifestations of angiodysplasia. It's hematochezia is not there.
Okay po.
Okay, so maybe you
Good
can
morning.
clarify that the clinical manifestations of angiodysplasia can range from occult GI bleeding, which can manifest as iron deficiency anemia, and then it can present as any of these. So melena, maroon stools, or bright red blood per rectum. Okay? All right. So sige, the next presenter.
Hey everyone. So I'll be presenting the diagnosis and management of angiodysplasia. So before everything else, correction of red cell and volume deficits is needed for the accurate evaluation of the patient. This is because the appearance of vascular lesions can be influenced by a patient's blood pressure, blood volume, and state of hydration. Such lesions may not be evident in patients with shock or those with severely reduced blood volumes. So first, for colonoscopy, this is the primary means of both diagnosis and treatment. So all lesions must be evaluated upon insertion of the colonoscope rather than upon withdrawal. This is because traumatic and endoscopic suction artifacts may resemble vascular lesions. So an angioectasia on endoscopy can appear as a 2 to 10 millimeter red lesion with arborizing ectatic blood vessels that emanate from a central vessel. So can my pointer be seen po? Hello po.
Use the no,
No,
use
it's not.
hand, the
Use
hand
the
icon.
mouse.
Use the hand
Use
icon.
the finger
There, there.
icon. There. Okay.
Mer meron na po, Dok.
Kanina.
Kanina lumabas.
Use
Nawawala
the
po
hand
dito.
icon.
Naglalag po ata.
Okay.
Yeah, yan.
Yeah.
Yeah.
Okay, go ahead. Regina, go
Sige na, di
ahead.
bale na.
Yes, Doc, okay po. Bali sa uppermost picture po, we can see this is an endoscopic image of an angiodysplasia in the ascending colon. So it has a typical coral reef-like pattern of small vessels distorting the mucosa and the submucosa. So next, we have the angiography. So this is used to determine the site and nature of lesions during active bleeding and can identify some vascular lesions even after the bleeding has ceased. So there are three reliable angiographic signs of angiodysplasia. So first, we have the densely opacified, slow emptying, dilated tortuous vein. So this can be seen in image A in the lower left pic on the arrows. Then this may persist late into the venous phase after the other mesenteric veins have emptied. So for the second sign, we have the vascular tuft. So this is created by ectatic venules that join the mucosal angiodysplasia and the submucosal vein. This is best seen in the arterial phase, and they may appear as small candelabra of vessels, as seen in image B, the thicker black arrow and the thicker white arrow po, yung sa baba po. The single big arrow po. And then for the third sign, the early filling vein. So this is seen in the arterial phase within 4 to 5 injection. However, this is not a valid sign if vasodilators have been used to enhance the study. So again, in figure B, this can be seen with the two double black arrows and then lastly, we have actually a fourth sign, which is the extravasation of contrast material. However, this is not specific. This identifies the site of active bleeding when volume is at least 0.5 ml per minute, but when in the absence of other signs of angiodysplasia, it suggests another cause of bleeding. So, other diagnostic modalities that can be done.
Regina, excuse me.
Yes, Doc.
So in relation to the earlier question of Dr. Ismail earlier on the specific findings on angiography, yung kanina was diverticular disease. So now there
Yes, Doc.
are there are specific there are findings that are suggestive of the cause of bleeding here, not just bleeding per se.
Yes, Doc.
All right. So while it's not very specific, but at least it can suggest that this angiodysplasia can be the source of the bleeding. And yung sinabi mo, yung fourth sign, which is non-specific at all, and it can happen in all types of bleeding, that there is an extravasation of the contrast material into the intestinal lumen. Okay, go ahead. Go
Yes.
ahead.
Okay. Other diagnostic modalities, which are radionuclide scintigraphy and the helical CT angiography. So first, for the radionuclide scintigraphy, it is usually followed by splanchnic angiography. This is used if the suspected lesion cannot be found or if bleeding is massive and colonoscopy cannot be performed. So at Natium 99M red blood cell scan. Wait lang po, Doc. Maganda po kasi pag may point.
Dr. Chan, yes.
Yes, Dr. De La Cruz. If
Yes,
you're
Doc.
mentioning again the TAG-RBC scan and the CT helical angiography, these are not used to diagnose angiodysplasia per se. I agree with you that the colonoscopy and the angiography, mesenteric angiography, can really give you a very important objective signs that it is a bleeding coming from angiodysplasia. and the helical CT angiography will merely tell you that there is lower GI bleeding, but it will not tell you it's coming from angiodysplasia.
Okay po to. So in this image in the left side, so we can see the right side and the left side. So in here we can see the liver in the right side, yung parang black part po. And then yung spleen po kasi hindi po masyado nakikita sa image na to. So I got another picture yung sa taas po, which yung may letter S po. Yun yung spleen po. And then going back to the figure below again sa radionuclide scintigraphy, yung vessels po, yung parang V-shape po, yung vessels. And then yung sa gitna may circle po. Yung sa second po, yung sa second 10 minute. Yan, yung may urinary bladder. So going back in this image, it reveals there's an increasing activity in the distal transverse colon near the splenic flexure, which is shown in the red arrow. So it progresses toward the descending colon and sigmoid colon by termination at 1 hour. So these findings are consistent with bleeding from a source in the distal transverse colon near the splenic flexure. And lastly, we have the helical CT angiography. So this is a relatively new, sensitive, specific, and well-tolerated technique to diagnose colonic angiodysplasias. So in this image, this shows multiple dilated vessels in the colonic wall seen in the 4 arrows po. And then, note also the early feeling of colic vein, the arrowhead only, and then simultaneous in the artery, which is the thick arrow. Then next, we go to the management of angiodysplasia. So we have the non-bleeding and the bleeding angiodysplasia. So for management of non-bleeding angiodysplasias incidentally found at colonoscopy, it is expectant. In such cases, endoscopic therapy is not indicated because the risk of bleeding in asymptomatic patients with angiodysplasia has been shown to be as low as 0%, which clearly does not warrant the potential risk of colonoscopic ablation. Then next, for bleeding angiodysplasia, so first we have to stabilize the patient. Then next, in preparation of the endoscopic ablation, aspirin and aspirin-containing drugs, other NSAIDs, anticoagulants, and antiplatelet drugs should be withdrawn for at least 7 days before the procedure, if possible. Then the following can be done: endoscopic therapy, medical management, angiography, surgery. So this will be further discussed in the succeeding slides. So first we have the endoscopic therapy. So there are a variety of endoscopic treatments that can be used to treat angiodysplasias, which are the following. But the most commonly used today are the argon plasma coagulation, also known as APC, and the heater probe coagulation. So what is APC? So APC is a procedure that uses a mixture of electric current and argon gas, which is applied through a non-contact endoscopic probe to the vascular lesions. So this has a lower penetration in the mucosa, thus the risk of perforation are quite low. On the other hand, in heater probe coagulation, the devices, okay po, Doc. So sa heater probe coagulation, important lang is yung it has contact with the lesion. So yung images natin sa uppermost po, in image A, we can see an actively bleeding angiodysplasia, which would be treated with APC po. So this is before coagulation. Then for letter B, we can see an argon plasma coagulation. During coagulation, there's a jet of ionized argon gas from the probe without contact with the vascular lesion, as can be seen in the arrow po. And then lastly po, in image C, after coagulation, so we have seen that the bleeding has resolved. Then for the middle image in letter B and C, this is both for heater probe coagulation po. So in letter B, there is multiple angiodysplasias in the ascending colon. And in the lower picture po ng B, we can see na the bleeding has resolved. And also in letter C, yung middle image po, yung upper po, we can see that there's a single angiodysplasia. And then we can see the picture of the heater probe, which is in direct contact with the lesion. So it has resolved. Then for the next, we have the angiography. So this is generally reserved for life-threatening bleeding who are not surgical candidates, for those in whom localizations of lesions is desired prior to surgical resection. So vasopressin was used in the past to control lower GI bleeding. It is given via an angiographic catheter placed into the feeding sac of
Regina,
red cells.
Regina,
Yes, doc.
this has the same principle as what was discussed earlier, di ba? So we
Okay
can
po.
move ahead. Just make note that angiography can be used to stop bleeding.
Okay po, doc. Then yung picture na lang po ng supercoil
It's
embolization po.
okay. It's okay, Regina. Continue.
Then lastly po, doc, we have the surgery po. So yung right hemicolectomy, the parts that are removed would be the ascending colon, part of the transverse colon, and the cecum. So this is indicated when angiodysplasias have been identified and when therapy by either or both colonoscopy and angiography is unsuccessful, cannot be performed, or is unavailable. And lastly, for subtotal colectomy, so almost all parts of the colons are removed except for the sigmoid colon. So this is done if the site of bleeding is not identified and when bleeding recurs or is continuous. Then, lastly, for medical management, so most patients with intermittently bleeding GI angiodysplasia require medical treatment in addition to endoscopic hemostasis. So medications that can exacerbate chronic low-level bleeding, in particular aspirin, NSAIDs, warfarin, and clopidogrel, should be avoided or at least minimized. So many patients can be managed with chronic administration of iron, so such as in cases of iron deficiency anemia, and occasionally may need erythropoietin injection, such as for those patients with severe anemia with chronic kidney disease. And then for hormonal therapy, this can this can treat patients with a variety of bleeding vascular lesions of the GI with procoagulant effect as basis. However, current studies do not support the use of these agents anymore to prevent the rebleeding from GI angiodysplasia. Then next, we have the anti-angiogenics.
Sorry to disturb you and to
Yes, doc.
interrupt, but this is a treatment for patients who have angiodysplasia and continue to manifest with anemia, especially iron deficiency anemia. This is not something that you do for patients who are obviously already having hematochezia, as was mentioned in the case. So you have to emphasize this, that this is not for patients with active bleeding.
Yes po, doc. For ano po, mga recurrent bleeding po.
And when just a question to you, because this has not been resolved, you and the other speakers have been always mentioning that when the patient continues to be unstable, that the patient will be or should be sent to surgery. Is there any objective criterion that can be used in order to send the patient to surgery, aside from what you mentioned as hemodynamic instability?
Yes, doc. So pag das for pag the patient is hemodynamic and stable, first we can perform angiography. But however, surgery may be indicated in cases where this diagnostic procedure is not available, and maybe if the lesion can be clearly seen, we can also do surgery po.
Yes,
Even with
Gina.
yes,
Yeah. Any other reason apart from what you have just mentioned? We keep on mentioning it about, yung instability cannot be done. Any other reason? Why would you send the patient for surgery?
Isaac would like to help Regina.
In emergency cases.
Yes, Isaac.
Siguro, Doc, yung sinabi ko po kanina na yung shock index po, which can be more objective po, yung heart rate divided by systolic blood pressure, since higher shock index would correspond to higher mortality and higher chances of hypovolemic shock, which can increase yung mortality nga po ng patient. So that can be a possible indicator for surgery po.
well, the shock index tells you only how the massiveness of the bleeding. It will not guide you as to whether you should send your patient to surgery or not. The shock index tells you that you have to do everything in emergency if the patient has a bad shock index. But there are more objective ways of saying that the patient needs surgery. And in the clinical setting, if the patient is unstable and needs more than 6 units of RBC in order to be hemodynamically stable over about 18 to 24 hours, then the patient should be already be considered for surgery.
Did you get it, Gina?
Yes, Doc. Thank you po.
Dr. Chen is mentioning about the amount of blood that is needed to be transfused to patients to maintain stability.
Okay po, Doc.
That is for all patients.
Then last,
You're talking about angiodysplasia, you're talking about diverticulosis. All right.
okay po, Doc. Thank you po. Then lastly po, we have the anti-androgenic. So this is so first we have the thalidomide.
I
So
think
this
we
is an
can do away
anti-androgenic.
with this, Gina. Last
Okay.
member of the
This,
group, why do you think this is angiodysplasia?
so lastly, our group thinks that angiodysplasia may be the cause of the lower GI bleed due to the painless recurrent lower GI bleeding, the patient's age, which is 78 years old, and she's also taking antiplatelets, and she has also associated constipation, which can lead to an increase in the intraluminal pressure.
And patient is hyper.
Tensive din po.
Okay, so for our last differential diagnosis, we have colon carcinoma. So worldwide, colon carcinoma is the third most commonly diagnosed cancer in males, second in females. It affects mostly males more than females. And then 1.8 million new cases and almost 861,000 deaths were recorded in 2018. In the Philippines, it is the most common cancer of the GI tract. Third most common cancer next to breast and lung cancer. And most cases are diagnosed 50 years of age and above. And over 3,000 new cases are reported annually. So as a cause of lower GI bleeding, it's the most common source of lower GI blood loss, but the bleeding is often occult. So, most colorectal cancer arise from adenomatous polyp. Uh, to define a polyp is a grossly visible protrusion from
Roderick,
the.
Roderick, I'm sorry to interrupt you. Can you go to your first slide, please?
Uh,
Can you go back? Is this correct? The most common source of lower GI blood loss, but the bleeding.
Pag occult lang po, pero pag like mga brisk
There's
bleeding.
something wrong with this statement. Are you telling me that common source of lower GI bleeding?
Dr. Chan, I think
you can say that the bleeding is
hemorrhoids.
Yes, go ahead. Yes, it's not the most common source.
Most common cause of occult GI bleeding.
Maybe, but don't say it's the most common source of lower GI bleeding. I don't think I will agree with that statement.
Okay, sorry, that's from
What? Okay.
up to date. So.
Go ahead po, Dr. Ismail.
If you read your Harrison, the most common source of lower GI bleeding in young individuals less than 40 is hemorrhoids. For those who are elderly, more than 60 and above, the most common cause is the verticular bleeding. That is from your textbook.
Noted po. Okay, so continuing po. So as mentioned, most of them arise from adenomatous polyp. It may be found in the colons of 30% of middle-aged individuals and 50% of elderly people, but only 1%, less than 1% becomes malignant. Yes.
Opo, Doktora.
Yeah. Are you going to discuss this? This is to be discussed in the SGD.
Uh, yes
The
po. Pero
pathogenesis,
like,
it's not part of
overview
your
lang, like, na-mention lang, ano,
Okay. See, so you go to your next slide.
next.
okay po. Okay, so the probability of an adenomatous polyp becoming a cancer depends on three factors. Number
Next
one,
slide.
Again, next slide ulit.
okay,
Sorry.
next po. Yeah,
Next slide. Next slide.
next week.
Next slide. This would be for later.
No, I
Wala.
I, I think excuse me,
Wala.
Dr.
Ano,
D, this is part
Risk
of the
factors is in
syllabus
the
for
guide
BGD.
question.
Yeah.
Okay.
ito na lang ito.
Yes, because you know because you need this, okay, as part of your reason to consider colon cancer as a possible source of lower GI bleeding for this patient. That's why we are asking you to present the risk factors. Not probably an in-depth
Okay.
discussion, but at least, try to present or list down the risk factors. Okay, go ahead.
So for risk factors for colon cancer, individuals high risk for developing them are those with hereditary syndromes, including polyposis coli, MYH-associated polyposis, and non-polyposis syndrome. It is mentioned that up to 25% of patients with colorectal cancer have family history of the disease. And also inflammatory bowel disease because cancer usually develops in 8 to 30% of patients after 25 years of having the disease. And for average risk individuals, those 50 years old and above usually develop cancers on 90% of them. And diet rich in animal fats or red meat, insulin resistance, especially those in obese patients, and diet with fiber. And also, tobacco use is linked to development of colorectal cancer, particularly after 35 years of use. And lastly, for unknown reasons, it has been found that individuals who develop endocarditis or septicemia from Streptococcus bovis have higher incidence of occult colorectal tumors. Thank you.
Okay. Good morning, doctors. Good morning, future doctors. Uh, in office with the clinical manifestations of colorectal cancer. So, symptoms vary with the anatomic location of the tumor, which differs if it's in the left side or the right side. It was mentioned earlier po kasi yun sa difference of the as anatomical yung ano po, yung diameter ng caliber of the lumen of the right side and the left side po. Colorectal cancer grows slowly. That's why it may present for as long as 5 years before symptoms generally appear. So first, for the right-sided colon cancer, the presenting symptoms are fatigueness, palpitation, shortness of breath, and angina pectoris, which is due to the iron deficiency anemia. And it may also present with hematochezia, which is mahogany-colored feces, with vague abdominal discomfort, palpable mass, and random fecal occult blood test may sometimes be negative. This is due to the fact that uh, the right-sided colon cancer bleeding is intermittent po. So next, for the left-sided colon cancer, abdominal cramping, particularly after meals. This is due to obstruction since the lumen is much smaller in the emitter. And there are changes in bowel habits, for example, from constipation to diarrhea, and hematochezia, which is bright red colored stool, with tenesmus, and with narrowing of the caliber of stool. And anemia is an infrequent finding po. So colorectal cancer should be considered in patients who are more than 40 years old when patient presents with hypochromic microcytic anemia on rectal bleeding and when there is abdominal pain and bleeding of any type. And colorectal cancer can also affect younger patients with inflammatory bowel disease and with a strong family history of colorectal cancer and other cancers. Thank you, docs.
Okay, good morning. I'll be discussing the diagnosis and staging of colon cancer. Actually, okay, so for the gold standard for the diagnosis of colon cancer, it is colonoscopy because aside from it being able to completely examine the entire colon and remove the polyps, it also allows biopsy for histology. One major disadvantage of colonoscopy, however, is it being the most invasive among the diagnostic procedures. Other disadvantages would include risk of bleeding or perforation, the requirement of bowel preparation, and it being operator dependent. Okay. CT colonography, it is also known as virtual colonoscopy. It is an alternative to endoscopy and has an equivalent sensitivity to colonoscopy. Now, just like colonoscopy, it allows full evaluation of the colon. However, it does not allow removal of polyps. Therefore, if there is presence of, of a polyp, the patient would still be referred for colonoscopy eventually. Now, for air contrast barium enema, it involves delivering a contrast solution into the rectum, and air may be pumped to expand the colon and improve imaging quality. So the picture here on the right shows a napkin ring lesion, or also known as apple core lesions. Now, this radiographic appearance is highly suggestive of malignancy.
Dr. Destura, excuse
Yes,
me,
po.
please again qualify the statement. You're showing us a picture of a barium enema. Although it can be used in the diagnosis of colonic malignancy, I would like to tell you now that this is never used for patients who are bleeding, as in the case
Okay,
that you are presenting now. Okay, we don't
okay,
use radiographic examination.
okay, noted, Doc. Okay, so staging of colon cancer is important because its prognosis is related to the depth of tumor penetration into the bowel wall, the presence of lymph node involvement, and also distant metastasis. So these variables are incorporated into what we call a TNM classification method. Okay.
Gail,
So, yes, Doc.
Gail, sorry.
Yes.
I'd just like to ask, how do you stage colon cancer?
Uh, we stage it based po dun sa three variables: the depth of the
Yeah,
tumor,
I know that,
lymph
but how
node
would you
involvement,
know?
and distant metastasis.
How would you know the M? How would you know the N? How would you know the T?
Okay.
Do you
Uh,
have a slide after this?
no po, last na.
Okay.
Todo.
So how are we
Pages
going
and
to state?
lastly, yes.
I think
What test would you do to stage?
yung colonoscopy po ba, Doc?
That's one.
No,
What
that
else?
uh,
Now we cannot actually stage
Wait,
the colon cancers based on colonoscopy. You can diagnose it.
Okay.
But how do you look at the depth of tumor invasion, the presence of lymph nodes, and distant metastasis?
Biopsy po ba, Doc? Or CT, CT colonography?
Okay. Well, anybody is going to talk about that, or maybe
treatment.
that
Bali, discuss ko po siya per stage. Ay,
Again, Gail, even if this is
yes, Doc.
good, the staging, we still need to find out how do we know it's T1? How we know it's T2? How do we know there's N? How we know that do we know there's M? So Francesca here mentioned CT scan. Correct. CT scan of what? Okay.
Maybe we can discuss that in the SGD. Let's just focus on the diagnosis of colon cancer as the cause of GI bleeding,
Okay
then
po.
the treatment.
Okay, agree.
Okay. Uh, so, I'll discuss this figure na lang po. So, for
No,
stage...
no, no, never mind, never mind.
Okay. Okay, Doc.
That will be in the SGD.
Okay po.
Good morning, Doc. For the clinical substitute for colon cancer, the optimal treatment is still resection of the tumor, specifically for the resected tumor. Now, we can also use adjuvant chemotherapy for those stage 2 high risk, stage 3, and higher. For the adjuvant chemotherapy, we use 5-fluorouracil leucovorin oxplatin, or otherwise known as Fulfox, for stage 2 high risk. And for stage 3, we use 3 months of capecitabine and oxplatin, otherwise known as Capiox, or 3 to 6 months of Fulfox. And for metastatic colon cancer, it is recommended that we use Fulfox or Capiox or Folfiri for metastatic colon cancer. Uh, Furthermore, every 2 months of chemotherapy, we check for the liver or lung for resectability. For advanced metastasis of colon cancer, we can also use monoclonal antibodies like cetuximab, panitumumab, and bevacizumab. Now, since this patient is a bleeding colon has bleeding colon cancer, it is recommended that we first use conservative treatment. We must first establish intravenous access, then rapid supplement of crystalloids and colloids to correct the shock, urgent cross match, and prepare. Yes, madam.
Yeah, I think we have discussed already the
Okay.
generalities,
Okay.
okay, in the approach of bleeding, massive at that, in any patient, whatever the cause is. So this won't matter actually. So you go straight to bleeding colon cancer.
Actually po, yun lang po, Doc, yung ano po, yung
Ito lang.
suggestion nila. Yes po, Doc.
So then the treatment will be the slide previous to this, no?
Yes po, Doc.
Okay. So continue as the last member. Ito na ba prognosis?
Prognosis po, Doc.
Okay.
So for the prognosis, individuals having colorectal cancer is related to the depth of tumor penetration into the bowel wall and the presence of both regional lymph node involvement and distant metastasis. Now, as you can see, further progression of stages results in lower 5-year survival. Now, we use 5-year survival as a method to measure curability because most of the cases of colorectal cancer have recurrences within 4-year period. Now, after tumor resection, other predictors of poor prognosis are tumor penetration through bowel wall into pericolic fat, poorly differentiated histology, perforation, tumor adherence to adjacent organs, and venous invasion of tumor.
For our final diagnosis, here are the salient features of our patient and our three differential diagnoses. We ruled out angiodysplasia since usually the patients with angiodysplasia are
Wait,
asymptomatic.
wait. Is this Alessandra?
Yes, doc.
How about Francis? Did you tell us why colon cancer is a consideration, is your diagnosis?
Feeling ko dun po sa next slide po.
Oh,
No. You have to tell us why your subgroup from Roderick to you believe or do not believe na this is a case of lower GI bleeding from colon cancer.
Okay po, Doc.
Why do you
So,
think, or why do you not think na it is colon cancer that's causing the patient's bleeding?
we believe po, Doc, na patient has colorectal cancer because of the patient's risk factors such as having history of colon cancer and history of smoking po, Doc.
History of colon cancer? Is there history of colon cancer? What do you mean history of colon cancer? In your case,
Ay, sorry po,
there's no.
Doc. Unlikely po, Doc, yung colon cancer po, Doc. Pero gusto lang po namin i-rule out po yun for early
Why nga?
diagnosis.
Why?
Why rule out? Di ba gusto mo i-rule
Yeah.
in?
Yes po, Doc. Gusto namin i-rule in po, Doc, so that
Yeah, why?
for early diagnosis po na if ever meron man, ng colon cancer.
No, what
In
in the
short,
patient's
yeah.
characteristics will make you consider or at least try to rule it out, no? Kung talagang gusto mo i-rule out na colon cancer. What in the patient's clinical characteristics will make you suspect or at least try to rule out colon
Okay po.
cancer?
The patient is beyond the age of 50 years old po, Doc, and history of tobacco use po, Doc.
Okay, that's the reason why. Remember a while ago, yung risk factors, you need to
Yes.
know that, diba? That will be the basis for considering one of the basis for considering a particular disease. Okay, Dr.
Sean,
Ome?
you want to say something, Sean? No more? Or I think we can go to Alessandra.
Yeah.
Size everything.
Okay, Doc. So again, we ruled out angiodysplasia for our patients since most patients with angiodysplasia are usually asymptomatic and the bleeding is recurrent and low grade. So this is not the case for our patient since our patient was previously well until the day of admission where she had 3 episodes of hematoplegia. Also, in patients with
Alessandra,
yes po, Doc.
rather than ruling out, can you just tell us a statement to the effect that you are considering one disease because of, rather than do it by, you know, uh,
Really?
exclusion, rule out, and then you're left with one, no? So can you do it in such a way that you are considering this disease as the cause of the patient's lower GI bleeding because?
Okay po,
Okay.
Doc.
Yes.
So for angiodysplasia, we are considering this since the patient presents with painless bleeding and also signs of anemia such as the uh, pallor that can be seen during the physical examination of the patient. And for colon carcinoma, as said a while ago, we are considering this because risk factors are present in our patients such as the age, more than 50 years old, and the tobacco use. And lastly, we are more inclined to diagnose this patient as having colonic diverticular disease because our patient presents with abrupt onset and painless hematochezia, which is a characteristic of colonic diverticular disease. Aside from this, the patient also presents with many risk factors such as more than 60 years old, hypertension, regular use of NSAIDs, and smoking. She also presents with other symptoms associated with colonic diverticular disease, such as mild lower abdominal cramps, orthostatic hypotension, and postural dizziness, which are signs of hemodynamic instability, and positive blood on direct rectal exam, which shows us overt bleeding. Yes, po, Doc.
Okay. All of this that you mentioned, all the manifestations of massive GI bleeding can be present in the three diseases, correct?
Yes, Doc.
Okay. You mentioned painless bleeding. Which among the three would present with painless bleeding?
Colonic diverticular disease po. And also angiodysplasia can
Okay.
present with.
You mentioned the risk factors, hypertension, age, intake of clopidogrel, etc. Are these present in both diverticular disease and angiodysplasia as risk factors?
Yes, doctor, didn't put
Okay,
angiodysplasia.
therefore, most likely, and your only reason for colon cancer is the age, right?
Yes, apa.
Therefore, most likely, your diagnosis will be either diverticular disease or angiodysplasia as the possible cause of lower GI bleeding, correct?
Yes, doc.
Okay, if you're going to choose between the two, which one would be your number one diagnosis?
Colonic diverticular disease.
Why?
It is more common din po than angiodysplasia.
Okay. See, that's the use of your epidemiology of diseases. Therefore, your statement should be the most likely cause of the lower GI bleeding in this patient is from a diverticular disease, no, because of the reasons that we have mentioned. And between the two, this is the more common. So that's it.
Okay po, doc. So with that being said,
Okay.
our final diagnosis is colonic diverticular disease.
Okay.
Thank you, doc.
Okay, so again, more on colon cancer in the SGD that will follow our next group's BGD. But may I just remind everyone to please the survey that we deployed last time, you can still access that. May I remind everyone to evaluate your session today, but you can still evaluate the session last time, last Monday. If you haven't done so, you can do it by going to this link, bit.ly/GI collab feedback, or you can just click on the link that is in your announcement page. You know, it's very important to us that we know how you experience all of these learning activities. So I think we can proceed with the next case. So again, it's just a reminder that you please give us your very valuable feedback on our activities. Okay, Dr. Velasco.